decision-making capacity. We're going to approach this by looking at the main concept first. The main concept of decision-making capacity is that the patient should be central in making a decision about his or her health care. In order for a patient to be able to do that, he should have access to information about the disease, about the plan, etc. Then the patient should have the ability to understand that. And then lastly, the patient should have the ability to rationally think the whole thing through. A combination of all these three things would be another name for informed decision making. Now let's look at the two terms capacity and competency, which have been used interchangeably for the same issue. Now, capacity in its simplistic form is defined as the individual's ability to make an informed decision. Capacity tests the ability of the person to understand, rationally think through, and be able to voice an opinion. Competency, on the other hand, is the ability to carry out a decision. It looks almost the same. However, capacity is tested by a medical professional, whereas competency, which is a legal term, is decided in the court of law. In many ways, the concepts are very similar. But let me give you an example. Let's see if two engineers are asked to give an opinion if the jet engine has the capacity to propel the airplane or provide the thrust. They may come back with the answer, yes, the engine has the capacity to propel the airplane, or does not have the capacity to propel the airplane. Armed with this information, the airline manager may decide that this airplane is competent to fly. So the concepts are very similar. It's just two different types of people deciding to go ahead with that declaration. The capacity consult. The capacity consult has been on the rise. There can be multiple reasons for that. We are more and more aware and sensitive to the patient involvement and opinion. That could be one reason. Patients are living longer and have more and more medical comorbidities that are often more complex. And then there are many reasonable options to choose from. Now, capacity also is neither static nor generalizable. Capacity can change, and capacity is very specific. For example, a patient who was delirious and did not demonstrate having capacity earlier on is now much better and can fathom the clinical situation and make rational decisions. So yesterday and today, the capacity evaluation yields a different answer. Now, capacity is specific. So a patient who cannot understand the depths of the clinical intervention may not have capacity to approve or disapprove of the clinical intervention. However, when asked about returning home or nursing home, he easily understands both concepts and can decide easily. So he has capacity for one thing, but not for the other thing. Now let's come to the question as to who is the best clinical person to assess capacity. Often it is assumed that capacity can only be tested by psychiatric professionals. That's not correct. Let's break it down and look at it thoughtfully. So for an assessment of capacity, there's some prerequisites. There has to be a clinical situation of an illness that has an expected course or untreated course. And then there's typically a proposed plan or intervention with its benefits and risks. And sometimes the expected course is that the treatment is complete and the discharge is in order with its benefits and risks as to where the person is going to go. And then combined with these two, the question is developed to see if the patient can decide or not. So if you look at it from an involvement point of view, it is the patient and the primary team that is most involved in all of these three. So technically, it should be the physician or the provider on the primary team who should be the first in line to assess capacity. Hospital bylaws typically decide who can do it, and most commonly it is considered well within the scope of all providers. And truly, it is in the best interest of all involved that the main provider taking care of the patient, who knows all of the details, should be the one assessing capacity, at least primarily. Now, why behavioral health or neurology or any other discipline, when they may not even know what the clinical situation is or what the proposed intervention with its risks and benefits is? Well, typically it is usually because there's a question. That is there a condition, a psychiatric one or a neurological one, which is coming in the way of the patient's ability to demonstrate capacity? Another reason is that sometimes there's a hope that maybe psychiatry and neurology can come and actually address the clinical problem and even help improve the situation for the patient, who can then engage for an informed decision-making process. So summing it up, ideally, the primary evaluation of capacity should always be done by the primary team. However, if there's reasonable concern that a psychiatric or neurological condition is present, then calling psychiatry and neurology totally makes sense. So now let's take a look at some of the examples where psychiatry and neurology can be particularly helpful. Now, internists and hospitalists often can deal with these things too, but psychiatry and neurology may be a bit more helpful here. For example, when a person is very depressed and is more ready to give up rather than treat himself, or a person who may be delusional and does not even believe that he or she has an illness and has no reality testing, or a person who, under the throes of an anxiety attack, cannot even engage, or stroke, or manipulative behavior where the person has a secondary gain, or sometimes when a patient who's going through an intolerable withdrawal and cannot focus on the illness that he got admitted for and is more inclined to do or make decisions based on the withdrawal. In all of these situations, a secondary evaluation of capacity is totally acceptable. Now we're going to talk about the technicality of doing the capacity evaluation. So how is it done? So there's about 5 items that you need to keep in mind. First of all is about clarifying what the capacity question is. The second is the capacity evaluation. You go ahead with the capacity evaluation after you've clarified the capacity question, in which you will try to understand the patient's ability to understand, compare it and contrast it with reality and objectivity, and then provide your opinion. This is what you are paid for. And then finally, after you've done the capacity eval, you want to provide an opinion about what should be the next steps. You should not just stop here. Now let's take them one by one in detail. Clarifying the capacity question means you need to understand what's going on, what's the proposed intervention, and what is that question. If you are part of the primary team, you know it all. But if you're a psychiatrist or a third party coming in for a second capacity evaluation, then you need to familiarize yourself with the capacity question. Now let's go and talk about the actual act of engaging with the patient to understand his or her understanding. So the first part is that you will try to understand if the patient understands the issue at hand and where is it leading to. So typically I'll ask the patient, do you know why you're here? Do you know what's going on? Do you know what's going to become of it? Simple questions like that will help you understand if the patient understands or not. Then you want to talk about the team's proposed plan and see if the patient knows it. And that if the patient knows if he accepts it or rejects it, what are the risks and what are the benefits. The second part is especially if he is rejecting the plan, or even if not, you can ask do you have any other thoughts in mind, any other ways of treating it, and then see if he or she comes up with some viable, reasonable alternatives and actually can voice the risks and benefits of taking that alternative approach. This is quite important. And then after you've seen this, you can ask the person if he or she has an opinion, and they should be clearly able to articulate an opinion. So that's the second major part. All of this will show you if the person addressed all of these questions in a rational way or not. Now let's go and see if once you've understood what the patient understands, then you need to corroborate it with objectivity, the reality, the actual situation on the ground, and see if the patient's understanding is correct or not. And then, based on that, you will provide your opinion if the person has the capacity or does not have capacity, because you could just match these two. And then finally, you want to provide some opinion about what next to do. Now, if you said capacity is present, then you have to tell the team that you think the patient's opinion is acceptable, even if it's not the same or the patient has rejected the proposed plan. When capacity is not present, there can be two situations. Either there's an emergency situation in which you must go ahead and ask the team to proceed with life-sustaining interventions. That's part of the common law principle of implied consent. Sometimes it's good to get a quick second opinion as well, that is it truly an emergency. It's not necessary for the team because it's an emergency, but it's always helpful. Now, if it's a non-emergency, you can say the person does not have capacity, and so we can do these three things. One is we can start looking for a guardian, surrogate, or something who can help with decision making, DPOA, for example. You also want to do these other two things. You want to recommend how we can improve capacity. And you also want to say that are there even more options that can be provided to the patient. So sometimes a further consult with a specialty service can help see if there are easier and more practical approaches that can be taken. Now let's summarize and offer some tips and tricks for certain scenarios. So in summary, capacity is different from competence. Capacity is the ability to understand, assimilate, and rationally manipulate data and provide an opinion. Capacity can change from time to time. It's not static. And capacity is very specific. You cannot generalize that the person does not have capacity for everything. It is best assessed by the team that's involved in the primary setting. Psychiatry and other disciplines can help, but they should be a secondary request for capacity assessment. And once the whole capacity assessment is done, there's always additional things that must be suggested or recommended. Now let's talk about some common scenarios which are sometimes very complicated. So let's begin with the person who is unable to engage. There are situations where a person cannot engage with you. They're sedated, delirious, intubated, or comatose even. In those situations, you typically say that the person does not have capacity. I just want to caution that sometimes you will see an awake patient who has aphasia or locked-in syndrome. Maybe an extra effort made to establish some way of communication needs to be undertaken before declaring that the person does not have capacity. In those cases, I would make sure that we engage teams such as neurology and others to make sure we come up with a combined approach to that thing. Now let's talk about a patient who's declining to engage. Typically, this situation arises because the patient is either angry or upset or just overwhelmed and wants to take some time before he or she engages. That is quite appropriate, and as long as there's no emergency, you can talk to the patient and reassure them that they can have their time and you will come back. Typically, getting some other people involved, such as a family friend or a family member, or even another staff member who has a better rapport, can sometimes be very helpful in setting the stage for a therapeutic alliance. Now, there are situations when you get those people who have a clear secondary gain and they're avoiding the question. They're disruptive or avoidant and do not want to address the question, whether it's about an intervention or it's about a discharge, and they're avoiding to meet with the clinical team and you as well because they're afraid that their secondary gain may be exposed. This is usually a complicated situation, and I typically recommend that let's call a complex care huddle and let's have all the team members talk about this and come up with a considerate but a unified plan of how to approach it. If a patient is well known for this behavior, then that's one thing and it makes it relatively easy. But if the person is a first timer in the hospital, one may have to begin the process of successive observations and documentation, which can help identify contradictory behaviors. For example, the patient may be very easily able to ask for food, ask for a newspaper, talk to the staff members, talk about their hobbies. They can manage TV, they can manage their demands, and even ask for their advance. But when it comes to the relevant question, they are avoidant and try to appear as if they don't understand it. This can be a slow process, but it has to be done in a proper, deliberate manner in which everybody gives them the benefit of the doubt, but also observes and documents it very clearly. Hence, the goal is to clearly document that the person is choosing to avoid the question on purpose. Introducing yourself. It is very important to clearly tell why you're there and who you are. What I've typically found to work very well for most situations is when I tell them who I am and that I'm part of the team, and my purpose of visiting them is because I understand that they have a medical or surgical issue and they're going to have to likely make some important decisions about it. And I tell them that my job is to make sure that they understand what is going on and what is the treatment team thinking. I comfort them that I want to make sure they have all the right information, and if they don't, then I offer that I can help them get that information. I also typically tell them that I would like to make sure that they can think of all possibilities and alternatives so that they can make the right decision. This gives them an option and also sets the stage very comfortably for the capacity-specific questions which I will have to ask later anyway. A few words on information received by patients. In my experience, I've typically seen that it is more often than not that the patients do not have full information. Even when the treating teams have delivered that information, sometimes the patients have not really understood it. There are many reasons for it. Typically, the patients have been inundated with enormous amount of information during their arrival and admission. They've been moved around quite a bit, and they get to see a number of new faces, each with their different style of delivering information. Capacity evaluation can go a long way in helping them get the right information as you ask them about how clearly they understand what's going on and what is it that the clinical teams are proposing. Now, sometimes in situations such as the one where the person is declining to engage or the person who has not received information, it's important to divide the evaluation in two parts. You can document that the capacity evaluation is pending a certain middle step. It could be about engaging the person who's declining, or it could be for the second type of patient who does not have information to provide more information. And then once the middle step is accomplished, you can go ahead and carry on and complete your assessment. A few words about cognitive exams and their relationship to capacity. Many mental status exams like the MMSE or MOCA are cognitive assessment tools, not capacity tools. In fact, we do not have any tool for capacity. While poor cognitive performance may affect capacity, there is no direct relationship. Let me give you a couple of examples. A psychotic individual with a delusion that he does not have an illness, when he has a profound gangrene, may perform exceptionally well on a cognitive test. In contrast, a moderately demented person may have forgotten all the information that was given to him. But once you sat down with him and were able to give him in one sitting all the relevant information of what was going on, you may see that the person does remarkably well with an objective understanding of the problem and demonstrates rational decision making. So while the cognitive performance was poor, his ability to understand the issue and deal with it rationally was well preserved. A few words about reassuring patients. It is our job to always comfort our patients. If the patient demonstrates capacity but disagrees with the team and wants to pursue his or her alternative, I remain very supportive. There are two reasons. Firstly, they have the right to decide as they wish. However, more importantly, it is important that you make it not an issue of shame or humiliation for them if their alternative does not work down the line. I typically would appreciate their ability to express their opinion, but I also ask them if they have some idea about what are they going to look for and how long are they going to wait before they say that their own alternative is not working out. I typically end it by saying that it is important for you to make the better decision and check out all the correct alternatives. But let's make a plan. If your approach does not work, how are we going to come back and reevaluate what can be done? That is typically very encouraging for them and actually helps them back off sometimes from their position. Lastly, I also reassure the clinical teams who may be either anxious or even offended if the patient refuses their suggestion. I appreciate them for being diligent and emphasize the value of diligence. I help them understand that they've done their duty well. I usually work with them to make sure that they're not feeling dismissed or rejected by the patient, and I try to see and dilute if there's any countertransference that may have evolved, so that the future negotiations with the patient remain thoughtful, pleasant, and supportive on all sides without any humiliation, shame, or guilt. Now, lastly, sometimes people feel very anxious about the whole capacity question and how to document it. Let me reassure you, it's pretty straightforward actually. If you think about it, you're just asking about 4 or 5 very specific questions from the patient and comparing them with what is objectively known. A concise, clear documentation describing the comparison and then your opinion is a good job done. Thank you.